Today, we're going to discuss a very important topic in intensive emergency. That is the pulmonary emergencies that we usually come across when you're working as an intensivist, or even when you have your ear duties and you're on your rounds. You would come across these particular patients who are having problem with the respiration. The usual symptom that you would be seeing and looking for in these particular patients would be cough. Either it can be dyspnea, which is basically the difficulty in breathing that is experienced by these particular patients. Then a very important sign as a doctor, you would be looking at this particular sign in these patients, that is hypoxia. Then we have the terminology of hypoxemia. Now, these two terminologies, hypoxia and hypoxemia, are basically not interchangeable at all. Hypoxia arises when there is a decrease in the oxygen supply to the tissue, and hypoxemia is basically the result of hypoxia, which is seen in the individual. That is basically the gaseous level of oxygen decreases in these particular patients. So sometimes they can occur simultaneously in the individuals. People having or experiencing hypoxia would usually go into a state of hypoxemia, in which the partial pressures of oxygen would decrease less than 60 millimeters of mercury. So this is a cutoff point that you would have to remember, that when you take the ABGs in these particular individuals, that is the arterial blood gaseous levels, that would indicate that the gaseous levels has decreased due to the hypoxia that is being experienced by the patient. So these are the particular signs that you would be looking for in the patient. And then we have another important sign that is noticed in these individuals, that is the hypercapnia. Now, what is this term which is known as hypercapnia? It's basically the increase in the carbon dioxide levels more than 45 millimeters of mercury. So this is again a very important cutoff point, just to exhibit and just to basically infer in these patients that the patient has the respiratory problems and the oxygen supply is decreased, the carbon dioxide levels are increasing in the blood simultaneously, and this is going to be quite critical for these particular patients. Now, when you would be going through the range of underlying pathologies that can basically make the patient end up in the pulmonary emergency departments, we'd be having a list of diseases out here. Specifically, we'd be discussing a very important inflammatory condition, asthma, which is quite evidently seen in the teenagers as well in the young adults. And then we'd be going through the very important clinical condition and pathology, which is known as the chronic obstructive pulmonary diseases. And basically, you would be noticing the fact that the whole respiratory passages are involved over here, starting from the trachea. We know we have a nasal cavity, the air enters through it. It enters into the tracheal rings, and then it basically passes on to the bronchi, and that is basically how it reaches into the alveolar sacs, where the gaseous exchange ultimately takes place in the individual. So it can be a pathology which is involving any of these structures. Either it can be the trachea that is involved, either the bronchi, or either the alveolar sacs itself. The lungs can be involved, and all of these can basically result in the pulmonary emergency of the patient, and then we would be needing all of these emergency tactics that we would apply for these patients to save the life as an intensivist for the patient. So this is again a very interesting topic that we'd be discussing over here. Starting off with the obstructive lung diseases. So we have the two major categories. We have the restrictive lung diseases, and broadly we classify and we have another larger group of diseases which is known as the obstructive lung diseases. Asthma or acute asthma is one of the conditions which is categorized in the obstructive kind of lung diseases over here. Now, why do we use these two basic terminologies, which are known as the obstructive, and then we have the restrictive lung diseases? Obstructive lung diseases are basically termed or they're pointing out those pathologies in which the tracheal ring, or it can be the nasal cavities, it can be the trachea, it can be the further bronchioles that can be blocked. There can be multiple causes for the blockage of these bronchioles or this tracheal ring. Either it can be the pathologies which are allergic in nature, or either it can be the pathologies which are basically inflammatory in their nature. So these are the two basic pathologies. It can be the neoplasms, of course, which can cause the obstruction of any of these air passages as well over here. So basically, the two major categories, you should make the concepts clear that how do we say that either it is an obstructive or either it is a restrictive lung diseases. Restrictive lung diseases occur whenever there is fluid around the lungs, for instance, pleural effusion or emphysema, which is basically not allowing the lungs to expand properly. And then we are basically terming these group of diseases as the restrictive lung diseases. So we'll be discussing that later on. And right now, on top of the list for the obstructive lung diseases, we have the asthma. Now, how do you define this condition of asthma that arises in these particular individuals? Now, this is basically an inflammatory condition, a chronic inflammatory condition that arises in the patients. It's kind of a hypersensitivity type 4 reactions. When we go into the detail of the kind of hypersensitivity that arises in these particular individuals, it is the type 4 hypersensitivity that arises in these individuals, and the resulting mast cell and the bursting out of the mast cells basically result in the inflammatory reaction that takes place in these particular individuals who have the asthma for a prolonged period of time. And sometimes these asthmatic attacks, they can be quite severe, and as a result, the patients can land up in the pulmonary emergency departments, and you should know how to treat and what are the particular kind of interventions that you're going to take for the particular patients who are suffering from an acute asthmatic attack. Now, these are the normal lungs that are shown over here, and as a normal lung structure, you would see that there is a proper space and there is no bronchoconstriction that is noted down in these particular normal bronchial construction. So as you compare it with an asthmatic bronchiole, you would see that there is a relative level of bronchoconstriction that is even normally present in these patients of asthmatic attacks or who are prone to the asthma for a prolonged period of time. It is a chronic condition. Asthma basically develops over a period of time, and sometimes the patient, when you would be taking the history from them, they would definitely tell you the fact that they are suffering from this particular kind of asthma, either any particular allergen or any particular pollutant is responsible for it. And then this condition gets aggravated from time to time, and they usually experience this kind of an acute asthmatic attack in which they usually would be telling you that they are on certain kind of drugs, bronchodilators or inhalers that are basically having the steroidal agents as well, and they're already using those particular agents for a prolonged period of time. So a particular degree of hindrance, a particular degree of constriction is already present in these individuals who are asthmatic, and they are known or already diagnosed cases of asthma. Then when there is an acute asthmatic attack, they already have a compromised system for the bronchioles, and whenever they suffer from this acute asthmatic attack, the bronchoconstriction is severe enough that it can prove to be fatal for these individuals. So this is a diagram in which basically you can compare the normal versus an asthmatic patient, a known asthmatic, and when he suffers from an acute asthmatic attack, his airways are compromised to the level that it basically needs an intervention. It's an emergency, and as a physician, you must be well versed with how to treat these patients, what are the particular kind of interventions that you're going to take for these particular individuals. On instances, we can even intubate these patients to maintain the airway, and obviously we have the three emergency protocols that we have to keep in mind. That is the A, B, and C. We have to maintain the airway, we have to basically maintain the breathing of the individual, and then we have to maintain the circulation. So this is the basic ABC in whatever emergency cases that you're going to take care of. You have to maintain the airway, breathing, and circulation of the patient. And moreover, then you're going to start off with any kind of interventions. Either it can be through medicines, through intubations, or whatever kind of respiratory support that the patient needs. You can provide that patient with this particular kind of intervention. So moving on, we have this particular kind of patients who are suffering from the chronic obstructive pulmonary diseases. Now, the chronic obstructive pulmonary diseases is a group of diseases. It's again a chronic condition that arises in the individuals. And we were sometimes using the interchangeable words such as emphysema for these patients of chronic obstructive pulmonary diseases. Some sort of changes occur in the lung architecture in these particular patients. Usually, when you take the history from these patients, they would give you a history of being a chronic smoker. So this smoking basically brings about a lot of changes in the lung architecture, and that basically results in the obstructive pulmonary diseases. A set of particular signs and symptoms are basically present for these particular individuals suffering from chronic obstructive pulmonary diseases. The signs and symptoms or the clinical features would again relate to difficulty in breathing, cough, and production of sputum is basically increased in these individuals. And then we have we can also see the features of wheezing or bronchial breaths on auscultation are also found for these particular patients. Now, there are 4 stages for the chronic obstructive pulmonary diseases. Mainly, we have the mild, moderate, and severe and critically ill patients are seen, and they are suffering from this particular kind of history. And the treatment would also depend upon the fact that which stage do these chronic obstructive pulmonary patients belong to. And according to that, we'd be starting off with the particular treatment in these patients. Now, when we got to have the research on the asthmatic patients and the chronic obstructive pulmonary diseases, patients suffering from this condition, we went through the fact that these two conditions basically have some exacerbating factors that differ from patient to patient. So even when we look in detail into the history and we got to know these patients, we just went through these particular facts over here, and the exacerbating factors or the factors that basically worsen the conditions in these patients related to the fact that the infections in respiratory tract were present for these particular individuals, and any kind of infections, either they are the seasonal infections, viral or bacterial in their nature, they usually exacerbated the already compromised airways in these patients. Then a lot of drugs, again, they basically, a lot of patients showed hypersensitivity to even certain group of drugs. For instance, a lot of patients showed hypersensitivity to the third generation cephalosporins. The use of these fluoroquinolones or cephalosporins, the patient would have the hypersensitivity reactions and exacerbated or precipitated an acute asthmatic attack in these patients. Exercises sometimes precipitated the acute asthmatic attacks, and some sorts of emotional stresses were also thought to be one of the leading precipitating factors over here. Then we have a lot of irritants in our environment. For instance, it can be the irritants that are present around in our environment, and they can be one of the causative factors as well over here. Any kind of exposure to dust as well as any gases can lead to the precipitation of these attacks. Aeroallergens, they can be the pollens. Sometimes you would come across these patients and they would give you the history that whenever there is this spring season, they suffer from an acute asthmatic attacks. So that is basically a reaction to the pollens in the environment. The pollen count basically rises during the spring season, and that precipitates the acute asthmatic attacks in these individuals. And then we have the GERD, that is the gastroesophageal reflux diseases. History is very important over here. Usually patients who are suffering from breathing difficulties that are associated with GERD, that is basically going to rise in upon, and the attacks are going to be more common when the patient lies down. That is basically exacerbating the GERD reflex, and in turn it is resulting in the breathing difficulty or the precipitation of the acute asthmatic attacks in these patients. Menstrual cycles, the hormonal imbalances can even precipitate the acute asthmatic attacks in these individuals. Cold weather is one of the important precipitant for the acute asthmatic attacks as well. Now, history taking is again very important over here, and you're going to highlight the points that we've already studied in the precipitating factors. Either there is some sort of a precipitating factor that is present in the history or not. And what is the exacerbating factor for this particular individuals? Not all precipitating factors are present in any one history, and you would have to look for the positive points in the particular history. For instance, you would look for the shortness of breath or difficulty in breathing. These are the particular signs and symptoms that you're going to look for in the history. Cough is again one of the important feature. It can be a productive cough, or either it can be a dry cough in nature. Tightness in chest, this is one of the particular terminologies that is used by the patient. So he would give you this tightness that he or she feels in the pericardial region or in the chest region, in the thoracic region, and that is why this condition is sometimes mimicked or sometimes confused with the MIs, that is the myocardial infarction. So this is again very important to rule out when you'd be giving out the laboratory investigations for these particular patients. You would be focusing on these particular facts as well. Chest pain, again, you would be looking at the fact that all of the features of myocardial infarction are present even over here. And sometimes when even the patients of myocardial infarction presents to you with difficulty in breathing and shortness of breath. So you cannot always rely upon only the clinical features, and you would always have to conduct the particular tests. The electrocardiographies are one of the diagnostic tests out here to rule out whether it is the dyspneic attack due to myocardial infarction or it is a pulmonary emergency. So differentiating between these two categories is very important clinically as well as on the laboratory investigations. Fever, so usually patients with asthmatic attacks also suffer from a low-grade fever because a low-grade persistent infection is already present in these particular patients. Purulent sputum is usually present, And then we have the typical findings of pneumonic attack that you would be seeing, the mnemonic shadows that would be quite evident on the chest radiographies. So this is quite evident, and this is how you basically move about and look for the particular clinical features, and they point out towards the fact that this patient is suffering from an acute asthmatic attack. This is the set of clinical signs and symptoms that you would be looking for. The history of COPD would, on the other hand, relate to shortness of breath. It would also encompass the wheezing. Then the patient would be also suffering from cough. So this is again one of the feature that is noted down over here, and sputum production is seen in these patients. And then we have the dyspneic attack, that is the shortness of breath and difficulty in breathing is again seen in these patients. So again, you would see that the set of clinical symptoms or the signs and symptoms that are seen in the asthmatic attack, they're quite similar as we see in the patients of chronic obstructive pulmonary diseases. The history is again the mainstay over here, and that is going to highlight whether the patient has been an asthmatic patient. Sometimes in a lot of cases they are known asthmatic or already diagnosed cases, so it is sometimes very easy to identify whether the patient is suffering from acute asthmatic attack or the patient has been suffering from some sort of chronic architectural changes due to any kind of habit such as smoking. So this is what you're going to highlight in the history, and accordingly you're going to treat these patients. Conducting a fruitful physical examination on the patient is very important over here, because when you have a detailed history at your hand and you've already noted down that this patient is either suffering from asthma or either the patient is suffering from the chronic obstructive pulmonary diseases, you would be very important, and very importantly, you would be conducting the physical examination to look for the positive points that are again confirming your diagnosis in this patient. Wheezing is one of the factors that can be even looked for on inspection. So when you inspect the patient without even physically palpating or performing percussion or auscultation, these are the basic 4 steps that you're going to conduct in the physical examination. Primarily, the inspection. Secondarily, we'd be conducting the palpation. Thirdly, we have the percussion, and then most importantly, we have the auscultation that is done with the help of a stethoscope. So these are the 4 basic steps to conduct the physical examination. After you have performed the general physical examination, you have noted down the vitals in the individual, having noted down the temperature, the respiratory rate, the blood pressure. All of these are the vitals that you have already gone through. And now you're just inspecting the patient. Any sounds that are being produced while taking breathing, while the performance of the breathing, that is basically known as the wheezing, the sounds that are produced during the breathing process. So if that are noted down, wheezing is positive, you're going to note that down in your, document that down in your physical findings. Coughing is again noted down for the individual, and then tachycardia is noted down when you are noting the heart rate for the individual. That is again the pulse rate that you're going to take for the individual. That is again going to note down whether the patient is suffering from any sort of tachycardia or not. This basically start off with the general physical examination, then the hypoxia. Hypoxia, as we already went through the fact that a lot of signs are sometimes present in the patient who are suffering from hypoxia. Signs such as cyanosis, the bluish discoloration on the distal ends of the limbs. These are the important signs that you're going to look for. And that is basically going to indicate that the patient is suffering from any sort of the hypoxic attack or not. Dehydration, sometimes we get a lot of patients, they are dehydrated, sunken eyes, and very elastic skin. That is basically, these are the important signs that you're going to look for in patients of dehydration. Tachypnea is again seen in these patients, and fever. Obviously, when you'd be noting down the temperature, that is going to indicate whether the patient is suffering from any sort of fever or not. Then we have the mucus plugging, and that is sometimes seen in the individuals, and sometimes even in the history, he would relate to these mucus plugs, and the patients can easily relate to them. We have the impaired gaseous exchange, that is again noted down when you are going to take the ABGs from the patient, and these are the particular signs, and these are the particular features pointing out towards the asthmatic attacks. The medical history, when we would be taking the history, there are a lot of risk factors such as an ICU patient, and we have the history of chronic smoking. So just noting down how many packs per day, the history is usually taken in this manner that you note down what kind of a smoker the patient was and for how many years he or she has been smoking. So these are the two major risk factors towards exacerbating or the asthmatic condition and towards the exacerbation and precipitation of the pulmonary obstructive diseases as well. The emphysema is one of the conditions, and that arises in these patients of chronic obstructive pulmonary diseases. As I've already mentioned, sometimes these terms are used interchangeably, and emphysematic conditions or in which the alveoli, they basically get shrunken, it results in the shortness of breath. So this is a particular sign that is seen in these patients, and that is why they basically have a lot of difficulty resulting in the redness and the pinkish discoloration of the facial congestion due to the facial congestion that occurs when they have these particular attacks of dyspneic attacks that they suffer from. And that is why they are known as the pink puffers. The congestion, the facial congestion is regarded as the pink puffing response that is seen in these patients. Chronic bronchitis is also seen in these particular patients. So whenever we have these patients with chronic bronchitis, you must know that what is the particular differential diagnosis that these patients are going to have. And again, you're going to focus on the history as well over here. The inflamed bronchial tube is the reason for the bronchitis. The features would consist of wheezing. It would consist of prolonged expiration, prominent rhonchi. Distant heart tones are again seen over here. We have basically seen obesity in these individuals, and then we have the peripheral edema that is also seen for these particular patients, and cyanosis, that is the bluish discoloration seen on the distal ends. It can be the fingertips, it can be the tip of the nose. That is basically resulting due to the hypoxia or the lack of the oxygen supply to these particular tissues that we see in these patients. And that is why they are known as the blue bloaters. So we have these two different patients, two different sets of patients, two different responses. Either they are the pink puffers or either they are the blue bloaters. Blue bloaters would be usually, blue bloaters are the patients who are suffering from the chronic bronchitis. And the pink puffers are basically the ones who are suffering from emphysema resulting as a result of the chronic obstructive pulmonary diseases. So this is the distinguishing factor between these two kind of patients. Laboratory tests are conducted for these patients, and we refer to the pulse oximetry, and that is going to basically highlight the fact that either the patient has the normal partial pressures of oxygen or not. Having the partial pressures of oxygen less than 60 millimeters of mercury is basically indicative of the fact that the patient is suffering from hypoxia. Hypercapnia was another feature that we went through, and that is basically the increase in the carbon dioxide levels to more than 45 millimeters of mercury. So this can be the two major indicators over here for the correct diagnosis. The blood gas analysis would also restrict the results towards the partial pressures of the oxygen as well as the levels of the carbon dioxide in the blood. And the alveolar ventilation is particularly featured upon. Respiratory acidosis is looked for over here and is basically indicative that the carbon dioxide levels are rising in the patient. which is basically resulting in the chronic obstructive pulmonary diseases, or the complete scenario of the chronic obstructive pulmonary diseases over here. Chest x-rays or the radiographies are something very basic that we're going to rely upon in these particular patients. They're going to reveal a lot of factors, and even whenever we have these patients of dyspneic attacks, we're also having the differential diagnosis of the heart failure. So the congestive heart failure, cardiomegaly, as you can see over here, there's an enlarged heart shadow, as you can see in the first radiograph, and that is indicative of the fact that the patient is suffering from the congestive heart failure. Then pleural effusion, the restrictive kind of lung diseases can also be ruled out over here, and any kind of effusion has these particular whitish shadows that is basically going to relate to the fact that the patient has dyspneic attack due to this pleural effusion. Then CT scans are also performed, and they are particularly to diagnose any sort of pulmonary embolism. Emboli can basically travel from the distal circulation towards the pulmonary circulation and can result in the difficulty in breathing, in dyspneic attacks, or in the pulmonary emergencies. So we have to particularly rule out these conditions. Apart from asthma, apart from obstructive pulmonary diseases, we have these heart failures, pleural effusions, pulmonary embolisms as one of the differential diagnoses in our minds, and these laboratory investigations, these radio imaging techniques are going to make the picture more clear for us. Then we have the peak expiratory flow meters that can even relate to these. They basically calculate the forced expiratory volumes, that is the FEV1 in the patient. So you ask the patient to take a deep breath and then basically expire fully, and that is basically going to calculate the forced expiratory volumes in the patient. And if you have these particular values, they can basically relate to the fact and the kind of the underlying pathologies that the patient is suffering from. So now, how do we conduct the ECGs for these patients? As I've already mentioned, the fact that a lot of cardiac conditions can even arise in these patients. ECGs are done, and they basically relate to whether there is any kind of a heart failure or a myocardial infarction attack that the patient is suffering from. And you're going to diagnose accordingly in these patients. Then CBCs, that is a complete blood count, and electrolytes are also done. Increased bicarbonate levels in total carbon dioxide levels are seen. Chronic hypoxia is usually seen in these individuals, and polycythemia is also seen as it's basically a compensatory effect that is seen in the individuals, as there is less oxygen supply. So there is a compensatory effect of polycythemia in these patients, and as a result, it's basically resulting in a complete clinical picture of chronic obstructive pulmonary diseases. The microscopic examination would reveal sputum with mycobacteria if the patient is suffering from tuberculosis. So this is very important to rule out whether he has some sort of a particular kind of infectious state, for instance, tuberculosis, and mycobacterium is present in the sputum or not. And accordingly, obviously, you're going to treat the patient. The drug levels are noted down. Theophylline toxicity is one of the conditions that can mimic the complete picture of the asthma and COPD. So you're going to look for the history as well. Differential diagnosis in the adults would also contain the congestive heart failure, pulmonary embolism, pneumothorax. Pneumothorax would be particularly related to the history of trauma. So usually the patients who have the acute history of chest trauma usually result and end up in the emergency departments as the pneumothorax and difficulty in breathing as well. Lung cancer patients and any kind of metastatic shadows, if they are seen on the chest radiographs, they are noted down for these individuals. Pneumonia, that is the shadowing, the particular mnemonic shadows that are seen, you're going to even look for that. So this is the differential diagnosis. It starts off from the heart failure, ranging from the heart failure, pneumothorax, pleural effusion, or even it can be the pneumonia that you're going to rule out for these particular patients. The children usually have the syncytial virus infections, and that is basically what you're going to definitively see in these patients. Airway diseases are also considered in children, and obviously there can be some sort of diseases that are inborn or due to the structural abnormalities or developmental abnormalities relating to the difficulty in breathing. So you're going to look for whether the child is suffering from some sort of structural abnormality, or either it is a foreign body aspiration, usually the inhalation of foreign bodies, because children are usually very fond of putting everything in their mouth. Usually the children aged 6 to 12 months, this is the particular age group for this. So this can result in the accidents, the typical accidents of foreign body aspiration resulting in difficulty in breathing, and usually the radiographs would reveal a lot of factors. So distinguishing all of these conditions or these particular scenarios in children and keeping in mind that children might suffer from these states will help you a lot in the definitive diagnosis of the particular patients. The treatment consists of providing supplemental oxygen. So, supplemental oxygen, maintaining the airway, maintaining the breathing, oxygen therapy is usually implied for, and carbon dioxide necrosis is usually seen in these patients. Then we have the hydration. You usually keep the patient well hydrated in this particular state, and usually pass on the double bore cannulas, and you start giving these particular hydrating techniques for these patients. Respiratory support is given. It can be any kind of mechanical support if the patient needs it. The BiPAP is one of the technique. Intubation, chest intubation is done for the patients. Tracheal intubation is done. Beta-adrenergic agonists are implied for. Then we can also resort to anticholinergics, and systemic corticosteroids are one of the drugs of choice over here to treat these acute asthmatic attacks. Antibiotics are also given. So sometimes it is not quite fruitful, and it has proved to be of no benefit if the patient is not suffering from any kind of underlying bacterial disorder. But still, antibiotics, for instance, Azomax, azithromycin, they were used, and doxycycline is one of the drugs that has proved to be very fruitful in these conditions, and the patients revive a lot to these kind of drugs. So giving these kind of antibiotics sometimes prove to be very beneficial for these patients. Other treatment modalities contain the magnesium sulfate. We usually give 2 to 3 grams intravenously, and is given 1 gram per minute to the patient. It basically results in the bronchial smooth muscle relaxation, stabilizes the inflammatory mediators, and it is contraindicated in patients who are suffering from hypertension, respiratory depression, and decreased tendon reflexes. So this is what you're going to rule out before administering magnesium sulfate to these patients. Then we have methylxanthines such as theophylline. We have aminophylline. They are the bronchodilators. They belong to the group of bronchodilators, and they are contraindicated in acute exacerbations of asthma, acute exacerbations of COPDs. They are basically the prolonged treatment that is usually given to asthmatic patients. Ketamine is one of the drug that is given, and is usually given in a dose of 1 to 2 milligrams per kilogram intravenously, and 4 milligrams per kilogram intramuscularly. Now, a lot of infectious states can even result in the pulmonary emergencies, and the infections can even range from the bacterial to the fungal to even the viral infections that can occur in the patients. Pneumonias is the particular word that is used for these particular conditions that arise. Acute bronchitis can also occur in these patients. If the lungs are not affected, the bronchi are affected, the airway, the air passages are affected completely through these pulmonary infectious states. And pneumonias can also arise when they're affecting the lungs, causing the lung fibrosis, or causing or damaging the lung architecture as on a whole. So this is the histological picture of acute bronchitis showing the inflammatory reactions that are seen for these particular patients. The inflammatory mediators are released and resulting in the overall inflammatory reaction. The clinical findings would be the cough, fever, we have chest pain, burning associated or not associated with GERD, and then we have hemoptysis, blood and sputum, rhonchi that is usually seen on the auscultation. When you perform the auscultation of the chest, you would see the wheezing sound, you would hear the wheezing sound known as the bronchial rhonchi. Pulmonary fibrosis is one of the complications that is seen in these particular patients. Now, the risk factors of the acute bronchitis would be the history of the smoking. So, the patients basically get more prone to this condition of acute bronchitis whenever they suffer from this particular history that is basically making the patient more prone towards this condition. A decrease in the immunity is again one of the factors that is going to increase the risk factors for the acute bronchitis. So any kind of immunodeficiency due to any kind of reasons, age, gender, or the physical condition of the individual is going to increase the risk of acute bronchitis in the patient. The treatment of the acute bronchitis would consist of intravenous fluids, so you would keep the patient well hydrated, antipyretics to control the fever of the patients, and cough suppressants are also given to the patients along with this particular, basically it's a symptomatic treatment. As you would even look for here, you are suppressing the cough, you are controlling the fever, and you're also keeping the patient well hydrated. Beta-adrenergic MDIs are given to the patient, and then we have the states of pneumonia. So apart from this less fatal condition of acute bronchitis, patients can also suffer from pneumonias resulting or ending up in the lung fibrosis. So this is a permanent damage that can occur to the lungs. So this is a condition that can even arise due to the bacterial or viral or any kind of origins over here. The symptoms would consist of the fever, again dyspnea, we have cough, pleuritic chest pain, increased sputum production, it is usually seen or associated with pneumonic conditions, and rhonchi and rales on auscultation are also found, that is basically one of the positive signs of pneumonia. So this is the complete clinical picture. Fever is one of the key factors over here. This is how you distinguish between an allergic cough and basically an infectious cough. Whenever there is fever, that is indicative, high-grade fever is indicative of the fact that it is due to some sort of an infectious state that is arising in the individual. Obviously, we're going to rely upon the cultures and the serological testing just to identify the particular organism that is responsible over here and then start off with the particular sensitive techniques over here. The laboratory evaluation is very important. You are going to perform pulse oximetry just to monitor the blood gaseous levels. Blood gas measurements are noted down. Performing ABGs is one of the key factors over here. White cell count to note down any kind of immune deficiency states that the patient is suffering from. Hemoglobin is also looked for, and we are also going to cater the hematocrit values over here. So this is the complete lab investigations that you would carry out for these patients of pneumonia. Risk factors would include any kind of immunodeficiency states. For instance, HIV is one of the viruses that can basically decrease the immunity of the individuals and make the individual more prone to the development of pneumonic states. Tuberculosis, Mycobacterium plasma is one of the infections that can arise in the individuals. Mycoplasma, and then we have the Legionella. So these are the particular organisms responsible to lower down the immune system of the individuals and resulting in the flared up picture of pneumonia in these particular patients. It's again very important to differentiate between community-acquired pneumonia and then we have the hospital-acquired pneumonia. This is very important, and history would obviously be quite suggestive for these patients. And how would you basically differentiate between these two states? Macrolide antibiotics are looked for, azithromycin is looked for, and then we're going to look for basically you're going to treat the patient with Azomax, and along with that you're going to give off the patient the macrolide antibiotics for the course is going to be of 5 days. So this is the particular treatment over here. Fluoroquinolones are one of the agents that have been tried and they have proved to be very beneficial. Levofloxacin is one of the drug of choice, and doxycycline in particular doses, for instance 100 milligrams is given to the patient, and again it proved to be quite beneficial for these patients of community-acquired pneumonias. Fluoroquinolones, levofloxacin and doxycycline is given for a period of 7 days. So this is again depending upon patient to patient, what the patient is more responsive to, and you're going to give the treatment accordingly to the patient. The treatment, you basically start off with the admission of the patient and then you extend with the spectrum of fluoroquinolones, macrolide, plus lactamase inhibitors in these particular patients. And then we have the healthcare-associated pneumonias, that is the HCAPs. And the history is again going to reveal a lot of factors over here. Particularly aminoglycosides are given because these strains are more resistant. So the typical drugs won't be quite effective over here. You're going to start off with the anti-pseudomonal drugs, and the cephalosporins are beneficial. In these cases, we have the beta-lactams and fluoroquinolones and aztreonam. As you would see, these are the quite third generation drugs that you would imply for the HCAP pneumonia. And why is this so? Because we are dealing with much resistant strains in cases of the healthcare associated pneumonias. History is again very important. You would ask the patient if he or she has been admitted to the hospital over 48 hours, for over 48 hours within past 90 days. And this is the particular history that you would be looking for, and that is indicative of the fact that the patient is suffering from HCAP kind of a pneumonia. And obviously cultures, sensitivities are going to be looked for even over here. Linezolid is one of the drug of choice over here, and we have vancomycin for the methicillin-resistant Staphylococcus aureus strains. So vancomycin is the drug of choice over here. So in today's lecture, basically we summarized and went through the different chronic inflammatory conditions that can arise, and the patient can end up in the emergency departments, and how are you going to diagnose, get a differential diagnosis, move on to a definitive diagnosis, and then follow a particular treatment plan for these agents and save the lives of the individuals. So that is the end of the lecture. Thank you for watching sqadia.com.